I'd like to continue with Micro 101. Since I didn't quite finish, I wanted to go over the antibiotics that are used for each um, classification of organism that I outlined. For alpha hemolytic streptococci, especially strep viridans, which can cause endocarditis, and pneumococcus, which obviously can cause respiratory tract infections. The most frequently used medications are the natural penicillins like penicillin G and penicillin V, and the immunopenicillins such as ampicillin or amoxicillin are generally sufficient for these organisms. First generation cephalosporins can also be used if the patient has a strong allergy to beta lactams. Other medications that are helpful include clindamycin, sometimes macrolides such as Zithromax if active, doxycycline, and levofloxacin. For the beta hemolytic streptococci like group A strep, group B strep, and others, which frequently cause soft tissue infections, non-pyogenic cellulitis, or involved in diabetic foot infections, strep throat. Again, natural penicillins, immunopenicillins can be used, as well as the first generation cephalosporins. Ceftriaxone is frequently used, mainly because of its ease of administration, since it's given only once daily. If, again, patients are allergic strongly to the beta lactams, other medications that are active against beta hemolytic strep include clindamycin, oftentimes, not always. Macrolides, again, not always. You need to check the sensitivities. Levaquin is typically active against the beta hemolytic streptococci. Intravenously, vancomycin, daptomycin, which are really the horse overall cover antibiotics for gram-positive infections. Very few gram-positive infections are resistant to those two antibiotics, as well as linezolid or Zyvox. For methicillin-sensitive Staph aureus, typically we use the anti-staphylococcal penicillins, including nafcillin intravenously, cloxacillin or dicloxacillin orally, the first generation cephalosporins, and again, if allergic, vancomycin, daptomycin, or linezolid, or sometimes clindamycin. For MRSA infections, our antibiotic choices are a little more limited, but there are many antibiotics that cover MRSA, most notably vancomycin, daptomycin, linezolid, ceftaroline, which is the only cephalosporin that covers MRSA, and even the long-acting antibiotics such as dalbavancin, which can be given as a single infusion and which lasts a full 2 weeks, but very expensive and generally is just given in infusion centers. The gamma hemolytic strep primarily is enterococcus, which again can cause GI and GU infections. And the strange thing about enterococcus is it's generally resistant to cephalosporins. So ampicillins and any penicillin is active generally against enterococcus, except the anti-staphylococcal penicillins, which are not used that often anyway. If a patient is severely allergic to penicillins, then sometimes we have to move to vancomycin, daptomycin, or again linezolid. For resistant enterococcus, VRE, which we see occasionally, antibiotics that are active against VRE can sometimes include ampicillin, but other times more broad spectrum gram-positive agents need to be used, such as daptomycin or Zyvox. Moving on to the gram negatives, I like to think of the gram negatives as in two groups. One are the easy gram negatives to cover, and the other are the not so easy to cover. And I should say there's a third group, and the third group is highly resistant gram negatives, including ESBL producing organisms and carbapenem resistant organisms. For the easy gram negative rods like E. coli, and Proteus, and some Citrobacter, medications such as ampicillin or first or second generation cephalosporins or quinolones or Bactrim can be used for these sorts of infections. For the more resistant gram negatives, such as Pseudomonas, resistant Klebsiella, E. coli, Providentia, Morganella, we have to sometimes use more broad spectrum beta-lactam, such as Zosyn, which is our go-to beta-lactam antibiotic, which is a combination of piperacillin and anti-pseudomonal penicillin and tazobactam, which is a beta-lactamase inhibitor. Third generation cephalosporins, fourth generation cephalosporins can be used for these more resistant gram-negative rods. And we typically see these in nosocomial infections, hospital-acquired pneumonias, diabetic foot infections where the patient has been on antibiotics time and again, so more resistant organisms develop. For the severely resistant organisms, the ESBL, we tend to use merem or meropenem, basically, or if the patient is discharged, ertapenem, which is only given once a day. The difference between ertapenem and meropenem should be noted, and that is ertapenem does not cover Pseudomonas aeruginosa. If the ESBL organism is sensitive to fosfomycin or sensitive to Bactrim or sensitive to quinolones, these can be used as well. For carbapenem-resistant organisms, especially carbapenem-resistant Acinetobacter, we are moving towards the use of Zacduro, which is a combination beta-lactamase inhibitor that has antibacterial activity in and of itself. It contains durlobactam and sulbactam in 1-to-1 weight combination, and Zacduro plus meropenem is generally the treatment of choice for severe carbapenem-resistant infections, also known as CRAB. For anaerobic coverage, the most pure anaerobic drugs are Flagyl and clindamycin. However, drugs that are used for mixed infections will also cover anaerobes widely, such as Unicin or meropenem or ertapenem or Zosyn. And those are typically given for infections that include anaerobes as opposed to just a strictly anaerobic infection. And that's the end of the continuation of Micro 101/Micro 102. See you on the floors.